Hello and welcome everyone. Thank you so much for spending part of your afternoon with us. We're really looking forward to today's program. My name is Emily Bell, and I'm the director of the American Cancer Society National Colorectal Cancer Roundtable. And today we're pleased to share with you a look into the NCCRT's latest resource that's aimed at supporting you in your work to deliver timely, quality colorectal cancer screening to the communities you serve in rural areas of the country. Next slide. And first, for those of you that are newer to our work, I'd like to share with you a quick overview of who we are and what we do. We were founded in 1997 by the American Cancer Society in partnership with the Centers for Disease Control, really with a commitment to reducing incidence and mortality from colorectal cancer, which is still very much our mission to this day. We are a coalition of over 230 member organizations, which include anything from state departments of health, cancer coalitions, federal agencies, nonprofit groups, health systems, community health centers, health plans, corporate associates, and many others. So really a diverse group of stakeholders that come together to support the work. We host webinars and programs throughout the year, deliver resources to aid you in your efforts, and then each year we convene the ACS NCCRT annual meeting in November to address important topics and set the agenda for the following year. So if you're new to us or getting to know us, I encourage you to go to our website at www.nccrt.org, get to know us and reach out if you have any questions. Next slide. So today our goal is to introduce you to the new Best Practices Guidebook, to deepen your understanding of the burden of colorectal cancer faced by rural communities, to showcase evidence-based interventions and promising strategies that you can adapt and apply to reach people for colorectal cancer screening in rural areas, to explore best practices and successes from healthcare organizations in Arizona and Alaska, 2 of the case study sites profiled in the guidebook, and lastly, we'll be sure to save time for Q&A with our presenters. The presentation portion of this session is being recorded, and the video recording and slides will be posted to our website following today's presentation. We'll hold questions for the end, so please submit your questions in the Q&A box throughout the program. And finally, we'd greatly appreciate it if you'd take a couple minutes to complete our evaluation at the end of today's webinar. Next slide. And now I'm pleased to introduce you to our presenters that are joining us today. We'll hear from Mary Carson Brown, a project coordinator with One Health Insights, the contractor that serves as lead author of the guidebook. Patty Molina, Senior Director of Community Health Services with Mariposa Community Health Center in Arizona, one of our case study sites. Cara Brown, Population Health Nurse with Bristol Bay Area Health Corporation in Alaska, another one of our case study sites. And Cara also generously shared her time with us as a member of the advisory group that guided the development of the guidebook. Next slide. And so before we dive in, we'd like to get to know you and the scope of the work that you're doing to reach rural communities for colorectal cancer screening. We can go to the poll slide. The poll question should pop up in a box on your screen, and be sure to find the scrolling bar to the right to scroll down to see both of the 2 questions. So we'll give you just a minute or 2 to take the poll. Okay, be sure to click submit if you haven't already, and we'll end the poll in just a moment and share the results with you. Okay, let's go ahead and close the poll. Great, so it looks like the vast majority of you are working with rural communities around colorectal cancer screening either at least once a week or on occasion, and many of you interested in doing so. And then great, it looks like many of you are also already working with community health workers or screening navigators in your work or interested in doing so. So that's really helpful. Our case study authors that you'll hear from later were especially interested in hearing about this, and we'll share with you some best practice tips. Great, so next slide. So to orient you to the guidebook, let's go to the next slide. The impetus for this guidebook is rooted in data. We know that people living in rural communities face higher colorectal cancer incidence and mortality rates, increased prevalence of risk factors associated with colorectal cancer, and unique barriers to colorectal cancer screening when compared to non-rural residents. And we also heard the need for this resource from our members and partners who spoke up at our annual meeting and virtual programs about their challenges with reaching patients in rural areas. And the need and interest is further confirmed by your participation today. We're really excited to see we've got over 250 people live with us, and we know that there are more that registered that hopefully will be viewing our recording in the next few days. So to meet this need, we set out to develop a guide to support key community partners in understanding and overcoming the challenges and common barriers to colorectal cancer screening in these communities. And while the guide is really targeted at health systems and community-based organizations, the practical tips and strategies can be adapted by other organizations, so such as health plans, state and local departments of health, and cancer coalitions, or many of you who are in roles that support those organizations that are actually delivering the screening. And lastly, we did our best to follow the advisory group's advice to deliver this content in a concise and easy to navigate format, which allows you, the user, to drop in and find the content that's most relevant to your needs. Next slide. And we'd also like to share our sincere gratitude with the many people that contributed to the guidebook. There are more than we can fit on one slide, but we really especially want to share our thanks with the advisory group. These members are rooted in the day in and day out experience of delivering colorectal cancer screening in rural communities and gave us incredible advice from their work across the country in developing the objectives for the guidebook, reviewing our case study examples, and down to the review at the end. We also really appreciate the support of our case study interviewees. We had 5 sites that contributed as interviewees, and then our contractor, One Health Insights, who is really a pleasure to work with and did incredible work. Next slide. So now we'll dive a little bit into the data around colorectal cancer and rurality. So in terms of defining rurality, before we dive into the data, we want to cover some terminology. So we learned quickly from the members of the advisory group that there's no single definition of rurality. State and federal agencies use different definitions of the term to determine things like eligibility for funding, data collection and analysis, and program administration. So the terms non-metro and rural are often used interchangeably, as are metro and urban. But for the purposes of this guide, we use the word rural in a general way, where rural describes communities of low population density, located largely outside of towns and cities, and remote describes the most isolated and sparsely populated rural communities. The common metric that we decided to use is the U.S. Department of Agriculture's Rural-Urban Continuum Codes, which categorizes counties as either metro or non-metro based on the size of their metro populations. And according to this metric, 14% of the U.S. population is considered rural, and 62% of U.S. counties are considered rural. Next slide. We know that the burden of colorectal cancer is higher in rural areas. So the prevalence of high-risk behaviors is higher among people in rural counties. Incidence rates are 16% higher in rural areas compared to metro areas, and 2 in 3 people in rural areas will be diagnosed at a late stage. And we know that diagnosis at a later stage often requires treatment by an oncologist, care that rural residents may need to travel long distances to receive. And then lastly, though we see that age-adjusted mortality rates have decreased dramatically since 1970, the decrease in mortality is larger in those metro areas compared to what we're seeing in rural areas. Next slide. Oh, I'm sorry, go back one slide, please. Okay, and then in terms of colorectal cancer screening in rural areas, people living in rural areas may not have equal access to the benefits of colorectal cancer screening. There's often limited availability of physicians and specialists. Many rural residents face a lack of insurance or underinsurance. Transportation barriers are common. In many rural areas, we see lower health literacy and limited knowledge about colorectal cancer and screening recommendations. We see social stigma associated with cancer and screening procedures, and then also concerns about privacy in smaller, close-knit communities. And lastly, we see screening rates are lower in rural counties. It's close. It's not a huge difference, but across the board, screening rates are lower in rural counties at a rate of 64.7% compared to metro counties of 66.6%. But it's certainly heterogeneous. So, if you look across the country, um, rural counties can be really different. If you're looking at, Texas border counties versus Minnesota or others, you really see a great variation across the screening rates. Next slide. And then with that, I'm pleased to introduce Mary Carson, who will walk us through the development of the guidebook and the methodology used to analyze the key informant interviews and arrive at key things. So Mary Carson, I'll pass to you.
Yeah, thanks, Emily. If you want to go to the next slide, Caitlin. Great. So as part of development of this guide, and in addition to conducting a literature review, some of the findings of which Emily just shared, we spoke with organizations who have successfully implemented evidence-based practices or promising strategies to increase colorectal cancer screenings in their rural communities. So to identify those organizations, NCCRT sent out a request to their members for success stories for consideration as case studies. And with support of the Rural Advisory Committee, we identified 5 case study sites among those submissions. So they're listed here. We will, for the sake of time, I won't get into them because we will be talking about them more a little bit later once we hear from a couple of those sites too. So next slide. So what do we want to learn? From the submissions, we did have some background on the populations that these case study sites served and what their efforts had been. So we wanted to spend our interview time digging more into their planning and implementation processes. So we wanted to learn more about the community and organizational barriers to screening that they experienced, why they chose the interventions they did, who was involved in funding, planning, implementing, evaluating those efforts, how they tailored their interventions, and then also any barriers to implementation, lessons learned, successes, and advice for other organizations. Next slide. So our analysis, after speaking with 9 individuals across those 5 case study sites, we had hours of transcripts to clean and prepare. There are different approaches to analysis depending on what kind of qualitative data you're using and what your end goals are. So with interview transcripts, typically the goal of analysis is to understand how they relate to one another. We wanted to look for themes that showed up across transcripts that could potentially apply to the data set as a whole. So got those steps kind of listed out here. We start by developing a code book to help categorize the content of each transcript, each interview transcript. After applying those codes, analysis continues, which for us included looking into things like code frequencies, so how frequently codes were applied, either in one document or across transcripts, and how codes overlapped with others. So we'll dig a little bit more into that analysis here shortly. Next slide. Maybe I think we might have skipped one. Yeah, great. So 2 of us collaborated to develop the code book, and we used the interview guide, our own notes from each of these interviews, and a review of the transcripts themselves, and also considered the goals of the project here. So what do we want the final product to look like? In this case, we wanted to have as Emily mentioned, an easily digestible guidebook, as well as case studies spotlighting these organizations. So codes are essentially just labels of ideas. We use parent codes, this higher level code in blue here, to categorize those ideas. On our first round of analysis, our code book had 11 of those parent codes and 48 total subcodes. So each code has its own definition. And we'll look at an example here. Next slide. Yeah, so here's an example. Under the parent code community challenges, we've got travel. And the definition in this case is barriers related to travel, transportation, and distance for colorectal cancer screening. And this details how the code should be applied throughout each of the interview transcripts. Next slide. Great. So here's kind of a screen grab of what our software looks like. So after developing the code book, you apply those codes to the transcripts, and we use a software called MaxQDA for our analysis. This is a slightly prettier version of what things end up looking like. But this is kind of what things look like as codes are applied to a transcript. So when we're reading through each document, we want to apply those codes to segments of text using the definition as sort of directions for when to apply it. And this section highlighted in red here is sort of a larger chunk. I believe it's a couple of sentences, but we apply those codes to bigger pieces of text so that the coded segment maintains its context. One of the unique benefits of using qualitative data is getting to hear ideas expressed in the individual's own words. So when we're coding, we want to maintain that context, and that also makes it easier for our analysis as well. So each code identifies a very specific idea, but when people talk, they don't stick on one train of thought a lot of the time, and it's totally fine. There's multiple points intertwined. So our coding often ends up like this. You can see multiple overlapping codes assigned to the same piece of text. And our goal is to kind of weed through it all. So where these points overlap here, that's what we call code relations. They end up being very central in our analysis because it starts to show connections that may not have been obvious to us initially. So I know you're just looking at a section of text here, but bear with me as I go through this example. I hope it becomes clear. But for example, here we might expect the patient barrier travel to overlap with, say, a clinic effort like reducing structural barriers. Here, the interviewee is discussing how long travel distances compound with the patient barrier here, knowledge, attitudes, and beliefs. Then this interviewee goes on to talk about how they use flexible screening options to overcome those challenges. So they highlight that as a success here. Patients are experiencing travel issues. We want to make sure that they have flexible screening options that suit their needs, and that is something that they considered a success. So you can kind of see here how these interactions kind of start leading you to themes here. We want to be able to understand the layers and nuance to the insights that interviewees are sharing. So after my co-coder and I, my colleague Michelle, work individually through each transcript, we merge those files together and meet to discuss our approaches. So were there any new codes that emerged? Do we feel that maybe some definitions need to be updated? It's an iterative process of coding, taking a step back, saying, how did that go? How are we feeling? Especially when you're working with another person. To code, you want to make sure you're both on the same page. So in our case, for this guidebook, we knew that we wanted to identify a handful of recommended actions. By the end of that first round of coding, we had a clearer idea of what those actions might be. So the 4 emergent codes we ended up with, next slide, let's see if we've got them here. Yeah, we're assess needs, so kind of a larger bucket code for those community and clinic needs and barriers. Assess resources, community resources and strengths were included in that. Addressing barriers, so planning and implementation efforts, and then impact, which included outcomes of those efforts, those successes, those lessons learned, things like wins in communication or community staff engagement successes, things like that. So we go back through again, iterative process of recoding the transcripts with these 4 emergent codes, which a little bit later you'll see what those 5 recommended steps are, and takes a little time and a little adjusting, and eventually we got there, but this was sort of the next step. So our analysis was built off of these codes, including looking at, again, where these emergent codes overlapped with our original code book most frequently. Next slide. So this is a lot to look at. We will look at a zoomed in version here shortly, but just to kind of show you big picture what we're looking at when we're doing this analysis. So we've got those 4 emergent codes in columns there, and all the rows are the other codes from the code book. So to give you some perspective, most of the codes overlap very few times. Those are those white and gray cells that you're seeing. So when we get more overlap between codes, those dark blue cells, that clues us into a theme there that we probably want to look a little bit more into. Next slide, a slightly simpler view here. Yes, so as an example, what you're looking at here are the codes that overlap with the emergent code assess resources. So things like partnerships, staff engagement, successes, primary care providing colonoscopies, and EHR utilization were the codes that overlapped there most frequently. So understanding these intersections really helps us to identify those actionable steps, as well as some of the tips and unique solutions that are included in the guidebook that you'll learn more about here shortly. I think that might be my last slide. Yeah, so back to you, Emily.
Great. Thank you so much, Mary Carson. It's always so fascinating to see the qualitative analyses like that and how much thought you put into it. So thank you. So in addition to relaying the themes that were uncovered from the interviews and from the lit review, we also wanted to root the guide in the evidence-based interventions that the Community Preventive Services Task Force recommends for increasing colorectal cancer screening. So next slide. These are, for those of you that have been working in colorectal cancer screening delivery for some time, these are the tried and true, sort of the treasure box we go to find interventions that are really going to support our work. And then more recently, multi-component interventions, so using more than one of these at one time, has been shown to be effective in increasing screening rates. So the guide reflects these, and many of the case study sites called on these interventions to support their work. And next slide. And then following the advisory group, we also sought case study sites that had experience implementing the following promising practices. So there's some overlap with the CPSTF categories, but we wanted to call these out as distinct since they are key areas that the advisory group members themselves felt that they could benefit from learning more about. Even, being people that are embedded in the work and seeing successes themselves. So these practices include optimizing EHR data, so increasing the capacity or improving the use of EHR and other clinic data to track screening rates, tailoring communication, so using communication tools to be more relevant or accessible to the patient population, primary care clinician colonoscopists. So this was really a hot topic among our advisory group. We had 2 case study sites, as you'll see, that had primary care clinicians that were trained to perform colonoscopies. 4 working with innovative partners. So we also learned about some really interesting case examples of working with innovative partners, ones that aren't necessarily traditionally affiliated with a primary care site, such as pharmacies, food banks, ag extension centers, and others. And then 5th, using data to tailor interventions. So using data, either at the clinic or local level, to really understand the patient population and tailor the interventions appropriately. So looking at the screening rate across different demographic groups or other ways to slice the data to really drill down and see which patients were most in need of screening and design an intervention that would meet that need. Next slide. And then we'll go to the next slide again. So informed by the lit review and the key informant interview analyses, we identified 5 recommended actions that can support your organization in identifying critical barriers, assessing resource availability, developing strategies to overcome challenges, and evaluating the results to build and sustain higher levels of colorectal cancer screening. So under each recommended action, we've included commonly seen barriers, tips for overcoming known challenges, examples from the organizations that we interviewed, and the numerous links to helpful tools and resources to help you implement the work. Next slide. So given that we just have an hour today, I'm just going to show you a snapshot of 2 of the 5. So not going very deep here, but wanted to give you a sense of what's included. So for the first recommended action, which is recognizing patient-related barriers, this action walks through how to consider the barriers that make it difficult for patients to access care, as well as barriers specific to colorectal cancer screening that may impact uptake. So some of the best practice tips include conducting patient or community surveys or focus groups, and reviewing articles focused on increasing screening in the target population, or considering secondary data sources. One of the resources included is our colorectal cancer data dashboard, where you can really drill down at the county level to see screening rates, incidence, and mortality across different demographic variables. And then for each of these actions, we point out a case study that had success in this area. For this one, it was the Colorectal Cancer Prevention Network based out of South Carolina. They continually assess the demographics and barriers faced by South Carolinians and then tailor their services to best meet their needs. So in this case, while the program has been doing the work for many years, over the last few years, they realized that they had a big increase in Hispanic and Latino patients served by their program. And so they actually hired screening navigators that are bilingual in order to meet that need and sort of adjust course and better meet the needs of their community. Next slide. And then the other recommended action we'll orient you to here is overcoming organizational challenges. So this action step covers common organizational challenges to screening and potential solutions for overcoming them, as well as tools to support your work. It goes into tips around supporting staff knowledge, capacity, and engagement, addressing EHR limitations, leveraging patient reminders and follow-up, navigating patients through the screening process, and points to some helpful tools and resources. So one being, we have a guidebook around lead time messaging, which walks the user through messages that you can use to reach patients as they're leading up to the screening age of 45, so that you can ensure that they're ready and primed and ready to come in and get screened right away at age 45. The case study site spotlighted here is the Bristol Bay Area Health Corporation, who you'll hear from in just a bit. They trained 2 family practice physicians to perform colonoscopies, really reducing the need for patient travel. So this is how they addressed their staff capacity issue and not having access to enough GIs to provide colonoscopy for their patients. Next slide. And then the guidebook also includes a deep dive, or I should say semi-deep, into the issue of primary care clinicians performing colonoscopy. So this is just one page, so it's not a manual on how to do this, but really a source of information on what we learned from the lit review, a lot of links out to other helpful information. But what we know is that colonoscopy screening is, of course, an essential component in preventing colorectal cancer, but patients may experience wait times for colonoscopies, and especially in rural areas, may have to travel long distances to a facility that provides colonoscopies. And additionally, as the lit review confirmed, as we suspected, that there are not enough GIs and general surgeons performing colonoscopies to screen every eligible person in the US. So we highlight 2 case study sites that did in fact train PCPs to provide colonoscopy. And then this spotlight really kind of goes into the issue and where to go for more information if this is something that you'd like to consider implementing in your clinic setting. Next slide. And now we'll get into the case studies. So identifying the case studies was really an exciting part of the process. We asked our advisory group for their advice around what sites had seen success and that we should profile. And then we also included in our newsletter a call out to our members and partners to submit their own successes, make the case for being included, and share with us a bit about what they did. And so we had, I think, 10 really robust submissions that each would have been incredible to include, but we went through the difficult process of selecting 5. So we include 2 federally qualified health centers, 1 health system, 1 critical access hospital, and 1 nonprofit organization. 3 of those identified as rural, 1 is remote, and 1 is a combination of rural and urban. And then we did, really keep in mind selecting sites that had that diversity of type, of setting, and then also geographical diversity. So you can see where the 5 are based around the country here. Next slide. And then you'll hear from Bristol Bay and Mariposa in just a moment, but wanted to give you a glimpse of the five as a set. So in addition to seeing, their type and how they classify themselves with the rural classification, you can see that where they selected which strategies were most helpful in increasing screening rates. So they each have 4 to 5 that are highlighted in their case study. Um, while there's only 4 or 5 highlighted, in many cases, the sites implemented several more. They all used multi-component interventions, so a combination of interventions to achieve success. The blue ones are those CPSTF recommended interventions, and then the orange ones are the promising practices. So you see there's kind of a mix of those promising practices showing up in each site and sort of giving you a different flavor for how they had success in implementing them. And then just one other thing to note here is that we're considering transportation support to fall under the CPSTF recommended strategy of reducing structural barriers. But of course, there's a little bit of gray area between these different types of strategies. So next slide. All right, so with that, I'm really excited to pass the baton to Patty Molina, who will share with you a bit about Mariposa Community Health Center. Take it away, Patty.
Thanks, Emily. Good afternoon, everyone. So my name is Patty Molina, and I am the Senior Director of Community Health Services with Mariposa Community Health Center, which is a federally qualified health center in Santa Cruz County, Arizona. It is very rural. Our electronic health record that we use is NextGen. Our population is only about 48,000 plus across, our 1,238 square miles. Our primary location is in Nogales, Arizona, which is the county seat. However, the largest area within our county is just about 10 minutes north in Rio Rico, Arizona, where we also have a clinic there. And then north of that, about maybe 15 minutes more in Tubac, Arizona, and then in the eastern part of the county as well in Patagonia, Arizona. So we have about maybe 26,000 plus active patients, all of them pretty much below that 200 federal poverty level. Most of our patients have insurance. There's about a 16% that do not have any. We do provide services within our own health system to be able to provide health insurance access to our patients. But the majority of our patient populations are Medicaid, Medicare, or Arizona Health Care, Arizona State Access Program, which is Arizona Healthcare Cost Containment System, which is our Medicaid program for Arizona. So we have a robust services that we offer, pretty much a one-stop shop for all of our patients. We are pretty much the sole primary care provider within the county. There's only one other private practice, but the majority of the patients come to Mariposa for all of their needs. We don't have any public transportation, so we do offer transportation for our patients, which is a really great thing that we can do, and not just in the Nogales area, but to all of our clinical sites, which is a really great thing that we do. So let's move on to the next slide. So a lot of the interventions that we do are promising practices. We belong to best practice groups across the country to ensure that we're a great model for other services that are being provided across our nation. So we have our community preventative services where we provide client reminders, and we provided specific training to the people who are making those calls, like motivational interviewing and making sure that we're sensitive to specific topics and why we're calling the patient to come in. And I can explain that more if needed, if anybody has a question specific to that. Engaging the work of community health workers, which are really the heart and soul of the community that I oversee. They really are truly the ones that know the community, they speak the language, they know where to seek patients, they know where it is to look for them, and make them a part of where they're at and in their neighborhoods, and create an atmosphere that is engaging so that they're able to come in for their wellness visits or well child visits, or even engage them in telemedicine, should that be by going to their homes and setting up the equipment there, because that might not be something that the family has or the patient has that they're able to do. As I said earlier, transportation support. This has been wonderful for all of our patients, since I said we don't have public transportation. So it is a great need that we have for our patients. The other thing that we're doing too is able to deliver prescriptions to them as well. But anything that we're doing, we are really focusing on the cultural competence, that language that needs to be spoken within all of our communication tools, whether it's in person, whether at the provider's office, whether social media, whether we're doing our Mariposa Talk Health with social media, or anything that we're doing is really important that we're tailoring the language specific to the area and being sensitive to the culture that we serve. And then, of course, we have many, many partners and collaborators in the community that we've worked with for a number of years. The health center has been around since 1980, and we've been here for a really long time, providing a lot of these services without any issues whatsoever. So it's just been really great, because these best practice models have been very proactive for us in ensuring that we're engaging patients that need to come in to seek services. Next slide. So with our colorectal cancer screening program, we engaged with our clinical pharmacy team to be able to create a model that we knew would get more people to come in and get screened. And so what we did is we discovered that there was a connection with type 2 diabetes patients that needed to that had a higher risk of developing a higher risk for colorectal cancer, basically, is what it is. So we worked with the clinical pharmacy team to be able to come up with a screening tool, which is what we see here in this slide right here, to be able to ask those questions and making sure that this was available at each visit with each provider if the patient met that criteria. We also developed the uh, patient, choosing the right tool. So it was a screening tool that was developed so that this could be within the doctor's office as well, talking about the different types of screenings that were available, and made it easy for them to be able to look at the colors and the questions on there and be able to have that conversation with the provider in the doctor's office without having, to worry about so many questions, because everything was listed on this sheet. So this was just a tool that was created that was easy. This is replicable, so you could make the design and make any tweaks to it. I'm happy to share this at any health center as well. The great thing about our program is that after the provider's visit, after the visits with the clinical pharmacy team, a CHW was following up with each one of these patients. And this is just because, that quick visit with the provider, the patient might still have a lot of questions. And there also might have been like a barrier either with language or a barrier with just understanding the material. So the CHW would make a call to the patient and ask if they had any questions. If they knew exactly how to use it, they would go by and they can do the steps by steps again. They could even go to their house and take a tablet with them and show them the video, or show them by instruction how they could use it. We also invited the patient, if they didn't want the CHW at their house, to come into the clinic and again just kind of have a one-on-one with the CHW to be able to learn that. The other things that we did too was we created opportunities for the entire community to engage. And so we had a colorectal cancer fair in March, kind of just highlighting that month. And so that's me right there standing in front of a giant colon where we had everybody coming in and they could walk through the colon and then just engage in education and learn about what the polyps mean and, what does a healthy colon look like. And then just all of the people that were there at the health fair just being able to participate with us and engage in the opportunity to learn more about what colon cancer is and how screening was important for them if they if there was certain criteria that you know that needed the screening. So next slide. So our progress to date, then this is from 2020 to 2024. Our screening rates were down. We were at 20%, and we increased with everything that we're doing to 26% by 2024. And then, you know, using all different forms, whether it was the colonoscopy or the FIT kit or using Cologuard. So either one. But our screening rates went up, which is exactly what we wanted it to do. I don't have numbers yet for 2025, but when we have that by the end of this year, we're probably going to see more of an increase on that, not just by the health fairs and the team tagging with the clinical teams and the clinical pharmacy team and the CHWs, but overall just putting posters up all over the place and making sure that people were aware that this was an important test that people needed to have and when and why. So those are always important right there. Next slide. So some of the lessons learned and best practice tips for you. So that shared decision making tool that I said I'm happy to share and you could replicate in your area. This is a really great instrument to have in those exam rooms because it kind of helps to open up and begin that conversation with the patient. You also can have them in the waiting rooms, and it just, you know, has something for them to grab, and they could take that into with the doctors like, hey, I want to talk about this. The follow-up calls to the patients by the community health worker, one of the most important and critical for our program's success. Just again, like I said, that the patients, the CHW has the cultural significance of understanding the language and just having them be available to be able to do a one-on-one, whether at their home or having the patient come into the clinic again in a non-clinical setting and sitting with them, just showing them exactly how to use, how to do any of the at-home tests was critical, and that was really helpful for us. And then of course any follow-up calls by the CHW. Hey, have you done the test yet? Do you need any help? Helping them understand how to set up the pickup and the delivery and where to drop it off. We even had CHWs available to go and pick up the kits if they were unable to come and bring it back to the clinic as well. And again, I can't emphasize again that the whole thing about the cultural norms, the language education levels, knowing your community, knowing what works, not using sophisticated languages or something that's above, you know, really the education level is quite important. And the CHW, that's just like the best that you can have in any setting to be able to assist with all of these projects, because they just have a knack of really getting the insight that might need and kind of really going in and looking at social factors, you know, that might be affecting that patient and why they might not be getting better. And we use this not just for colorectal cancer screening, but for other things like diabetes, for example, and they can go in and do a home assessment with the patient and really find out a lot of in-depths about the patient and how we can help them and really understanding those social determinants of health. And I believe this might be my, okay, next steps. Okay, so again, our quality measures is something that's really important that we need to emphasize, and colorectal cancer screening is right on top of there. So we are continuing this approach. We are going to continue with our integrated team-based approach using the clinical teams, the clinical pharmacy team, and our CHW, empowering all of our auxiliary staff as well to be able to help and kind of like, you know, just point those things out with our posters and our flyers out in our lobbies and everywhere else that we have them. We're going to continue with patient outreach and education and community awareness every March. If we can do this colorectal cancer screening, colorectal cancer awareness campaign with health fairs, we're going to continue to do that. If I can get that colon back on campus, that's going to be really great. And then with specifically with Exact Sciences, working with those product representatives has been really great. They've been able to provide a lot of information and insight to us, and then materials that make it easy for us to be able to have specific education material available that we can share with patients. So that's been really great, and they've been really proactive in coming in and bringing Spanish language education to us, which is what's really important in our area as well. And I think that is the last one, so I'm going to pass it to Cara. Thank you.
Can you hear me okay?
Yes,
It should be
correct.
working now. Okay. Good afternoon. Thank you for having me today. I would like to give you a little bit of information about the Bristol Bay Area Health Corporation, where I work in Southwest Alaska. We are an extremely remote facility. We are a health center, but we also have a 16-bed critical access hospital attached to our facility. So we serve a region approximately the size of the state of Oklahoma. And within that region, we serve about 6,000 patients. So also within the region, there are 28 villages that are not connected by road. So we only have one village that's actually connected by a road system to the main hub of Dillingham in Bristol Bay. So most of our patients end up traveling extremely long distances on small bush planes and some of them by snow machine. We have 22 clinic locations in the region that all of our physicians travel to. However, we only do colonoscopies at the main hospital in Dillingham. The important thing to note about Alaska in general is the Alaska Native population actually has the highest CRC incidence and mortality in the world. So CRC screening is very important to us. It's a very high priority. And a lot of the work that we do would not be possible without a grant that we received from the Alaska Native Tribal Health Consortium. So a lot of the funding that we receive has gone to all of these different types of activities and initiatives that we've done. Next slide, please. So for evidence-based interventions and promising practices, we also use client reminders such as birthday cards. So when patients turn 40, we send them a card in the mail encouraging them to come and get their colonoscopy done. And you might be thinking, why age 40? Why are you sending a birthday card at age 40? But for the Alaska Native population, the screening age was lowered several years ago to start screening at age 40 instead of 45. So we actually start 5 years earlier than most other parts of the country. Patient navigation is so incredibly important in the work that we do. So we have myself and another patient navigator, and really our job is to provide outreach and education, build awareness, assess and address any barriers to screening that our patients might have. We help review and educate patients on the bowel prep process. We update medical records. We also are responsible for arranging travel and lodging because we do have patients traveling sometimes 2 hours, 3 hours, just to get to the hospital for this procedure. And then they're spending the night, sometimes 1 to 3 nights in a hotel and prepping in the hotel. So we're really, helping coordinate care for all of these patients to get to Dillingham. And our ultimate goal is to get patients screened. So we really want to break down any barriers that they might have. We also looked at our EHR data because we switched over to a new EHR system, and it did not carry over some of the information from the medical records. So we did a massive chart review and we updated any eligible patients that were due for a colonoscopy and added in when the last procedure was that they had, so we could actually do outreach to the appropriate group of people. The other thing that we've spent a lot of time doing, and Patty mentioned this as well, is tailoring the communication to our patient population. So there are many patients in our region who speak the Yupik language, the Alaska Native Yupik language, and English is their second language. So we started an endoscopy revitalization project several years ago, and we updated all of our patient education materials, our bowel prep instructions, our reminder letters, And then just in March of this year, we completed a patient education video in both English and Yupik that walks patients through how to do the prep. We also included a very strong patient testimonial that was just incredible in that patient education video. And then lastly, we do have 2 primary care physicians who are trained to do colonoscopies. If we did not have these providers, we would be sending hundreds of patients to the Alaska Native Medical Center every year to have the colonoscopy done. So keep in mind, they would be traveling from Bristol Bay over to Anchorage, which is an hour by plane, and then spending several days in like a patient housing or a hotel to have this procedure done, and then flying back home with their escort. Next slide, please. So, oh, there we go. As I mentioned before, we did start an endoscopy revitalization project, and part of that was to really simplify the CRC screening process for patients in our community. So since we had patients traveling such long distances and they were expected to prep outside of their home, we implemented these colonoscopy prep care packages, which is essentially just a dry bag that we filled with a glass mug for hot liquids. We included things like a water, an apple juice, some really soft wipes that they could use, tea, ginger tea, things that they could use during the prepping process. So these were specifically for patients who were coming from the villages to make this a little bit of an easier process for them. And the work that we did with that, we actually did receive a SCOPE award in 2023 from the American College of Gastroenterology for the best coordinated community awareness campaign in health intervention. So our care packages have been a big hit with the patients, and there have been other tribal health organizations within the state of Alaska that have actually started implementing the use of those as well. As I mentioned before, we do have about 2 family practice doctors, and we do about 200 scopes a year, give or take a little bit there. And then I did speak a little bit already about tailoring our outreach messaging to our Alaska Native population. We also have a large Nolan the colon that we use in a local parade and some other costumes. Let's go to the next slide, please. And you'll see a picture in the bottom left corner. We put the Nolan the colon on the back of a flatbed trailer and take it through the parade. And then we also had some other costumes this year that we added. We did another campaign in March that was called Get Your Rear in Gear. Since we have a lot of patients who like to ride their snow machines in the winter, we tried to come up with a fun campaign event. So if they scheduled their colonoscopy during the month of March, we offered them a chance to win a $150 gas card and a gas jug. So that was another really fun initiative. We also did the Cancel Cancer coffee cup sleeves this winter, and had those printed and gave them out to a couple of different local coffee shops in the area. Next slide, please. So our progress to date, and then hit the next slide button one more time, I believe. There we go. So from May of 2022 until June of this year, we had nearly a 30% increase in our screening rate. And as you can see from the data, it is a little bit more challenging to get in the males rather than the females. So looking at ways that we can engage them is definitely helpful. Next slide. Lessons learned, definitely use your patient navigators to connect with patients. We do not have community health workers at our facility, but patient navigators are definitely the key to achieving this work. Tailoring education materials to be culturally appropriate and easy to understand. And then also implementing the evidence-based interventions into your practice. So patient reminders, provider reminders, reducing structural barriers, and then provider assessment and feedback. And those actually all come from recommendations from the CDC. Next slide. So some of the next steps for us, we would like to be able to use text appointment reminders with links to prep instructions. We don't have that set up yet, but it is in progress. We also did an Iditarod cancer screening challenge. You can see the poster there on the slide. We did this in the winter to try to increase our screening rates. We had our care teams involved with this, but we'd like to create maybe a salmon-themed screening challenge for the summer, since Bristol Bay is actually the home to the world's largest wild sockeye salmon run. So fishing and subsistence and hunting are very important in our community. And then we'd also like to start tracking some colonoscopy quality measures, such as the adenoma detection rate, the cecal intubation rate, withdrawal time, and the bowel prep quality, which we have just started this last week. So that is all that I have. If you guys have any other questions, though, we'd be happy to answer them during the Q&A. Thank you.
That was phenomenal. Patty and Cara, you are getting so many kudos in the chat and so many questions are coming in. So it's really, really exciting to see that. Thank you for sharing. So I want to invite all of our speakers to come on camera and come off mute. We only have a few minutes left, unfortunately, so I'll move quickly. First, I just wanted to address, we had a couple questions about the idea of PCPs providing colonoscopy, and someone had asked what training is required. So I'll just share a little piece that's inside the guidebook, which is that the American Society for Gastrointestinal Endoscopy suggests that clinicians who have not received training through the conventional routes, like GI fellowship or surgery residency, receive formal hands-on training through a preceptorship, sabbatical, or education in a practice setting by a qualified endoscopic instructor, and perform at least 100 supervised colonoscopies. So that is, based on that one society's recommendation, and then other societies also point to that recommendation as a best practice. So, for other questions, I definitely recommend, start with reading what's in the guidebook, follow the links to the other organizations that are really focused on this topic, and then reach out to us with any remaining questions. So back to our presenters, there was a lot of interest around your work with community health workers or navigators. So for each of you, we have questions around, for those CHWs and screening navigators, do these individuals help patients sign up for insurance if they're uninsured? And then also, do you have any suggestions for training programs to teach CHWs about motivational interviewing? So Patty, I'll let you go first. So again, do they assist with signing up for insurance? And then also, if you have any recommendations on motivational interviewing?
So I responded to both within there, so I'm not sure where they'll go to or how they'll, but hopefully they'll get that. For motivational interviewing for our state, we have the Arizona Community Health Workers Association, ASCHA, which provides tremendous support in terms of any types of training. For motivational interviewing, and I go back, over 20 years that we had it, there was a really great Dr. Rhodes who did it for us, but there's so many trainings now are available, but specific for CHWs. For us, we went through ASCHA, but there is the National Association of Community Health Workers where you could probably find that information there. And in terms of the insurance, we have navigators that will do the insurance work for us, so not necessarily the CHWs. However, if it's specific to Cologuard, they do have an assistance, a patient assistance program that the CHW can refer the patient to.
That's great. And then Cara, we have less than a minute, but if you're able to touch on that too, that'd be great. Oh, you're on mute.
Sorry about that. We actually don't have community health workers, but the patient navigators that we have, it's really just myself, and then our endoscopy technician also serves as a patient navigator. So I think any questions regarding CHWs would be best answered by Patty.
Okay, that's great. Thank you so much. Unfortunately, we had more questions than we can address, but we'll try to get to many of those afterwards. There was also a lot of interest in some of your resources, Patty, so we'll follow up to see if there's anything that we can host on our webpage. So with that, thank you again. I want to just share a quick notice that none of our panelists or speakers have any disclosures to make. And the next slide, just wanted to share, tips for getting engaged with us. You can follow us on social media, sign up for our newsletter, consider applying for membership if you'd like to remain engaged with NCCRT and be an active participant. And then with that, I'll just point you to our evaluation link. We'd really appreciate getting your feedback on the program. We always adapt our programs to try to meet your needs. So thank you again to all of the presenters. Thank you to all of our participants today, and have a lovely afternoon, everyone. Thank you.